Welcome to week 4 of HHS Telemedicine Hack. We can put up the first slide, please. I'm Captain David Wong with the U.S. Department of Health and Human Services. For those of you checking out TM Hack for the first time, what makes our community different than other telehealth resources is our focus on peer-to-peer learning. Every one of our 10 sessions is anchored by at least 1 or 2 case presenters from the field. We also have discussion boards through our partner Train, where additional peer-to-peer and peer-to-expert engagement can occur inter-session throughout the 10 weeks. Our vision is that through this community of peer-to-peer learning and providing the proper infrastructure, tools, and resources, our diverse community of ambulatory providers of all different sizes, shapes, and flavors can pick each other up and get everyone to the finish line. Our goal is by September 30th, we will have at least 90% of participants that will have conducted and build at least one video-based telemedicine visit in time for the fall COVID-19 surge. Next slide. We always like to start with our curriculum roadmap. Next slide, please. And so with this roadmap you see on the right, there's 5 topical sessions that we developed in consultation with over 12 ambulatory stakeholder associations. These were topics that were hot topics that members were asking about and wanted additional knowledge and instruction. We also have paired each of these 5 topical sessions with 5 office hours, as you'll see on the left. And this is again to make sure that communities, particularly ones of this size, have opportunity for folks to get their questions answered. These office hours are also an opportunity for us to invite guest panelists from other stakeholder associations and groups. And today, for office hours number 2, which is where we're at, we have special guest panelists from American College of Physicians and the Digital Medicine Society. Throughout this curriculum, you can see it's also very progressive. And over time, we hope that we not only can get folks added onto telemedicine implementation, but also folks that have already done it, that they will continue to build their skills and confidence. And with that, I'll hand this over to Bruce Struminger, who will be a co-moderator for today's session.
Great, thank you, David, and welcome everyone. As David said, I'm Dr. Bruce Struminger. I'm a general internist at the University of New Mexico and an associate director at Project ECHO. It's really an honor to be helping facilitate this telemedicine series. I'll be co-moderating with Dr. Christian Reimers, and you'll be meeting him in just a moment. But first, just a few logistic issues. One, we want to let everyone know that we're carefully handling the data you're sharing with us when you registered, when you put questions in the Q&A, et cetera, that all that data is being very carefully stewarded. Next slide. So hopefully everyone's noticed down at the bottom of your Zoom toolbar, there are a few buttons. One is a Q&A function. Please put your questions and comments related to today's session there. We will be carefully monitoring that, and many of our panelists will be answering those questions real time. So please share your questions and comments there. If you have any technical or logistic issues, please note those in the chat function. That's a separate button along that toolbar. So this session is being recorded, and your attendance is consent to be recorded. Thank you for that. We'll be making those recordings available later. There will be CME and continuing professional development credits available through the University of New Mexico, where Project ECHO is based. There will be a link in the chat about 15 minutes before the end of the session, and there should be a link in the announcement that went out this morning to everyone. You'll have up to 48 hours to complete the survey and get your instant CME. We really value your feedback, so please take advantage of that CME opportunity. Next slide, please. So how to ask questions on this session. Please be as specific as possible. The more details you can share, the better. To help us in answering your question, if you can mention the state where the patient, if you're talking about a patient issue, where the patient is located, where the telehealth interaction is taking place, also where the provider is located, that will help give context. Let us know the type of provider, whether it's a hospital-based situation an FQHC, a solo practitioner, or a nurse, etc. And also for billing and reimbursement issues, please include if you're asking about Medicare or Medicaid or a private payer. Also, please post additional questions to the trained discussion boards. Telehealth Resource Center staff are going to be reviewing those discussion boards periodically, and answers will be available to the entire Telemedicine Hack community. Next slide. Great. So just again to review the agenda, we're going to start out with a case presentation, and that will just be a quick 10-minute presentation followed by 5 minutes for questions. And then the balance of our time will be spent on Q&A. So with that, it's really my pleasure to introduce Dr. Kyle Knierim. Kyle is a family medicine associate professor at the University of Colorado in the family medicine department, where he also completed a fellowship in primary care practice transformation. He cares for patients and trained students and residents in the family medicine clinic there. He's also the associate director of practice transformation at the University of Colorado. Today, Kyle's going to be talking about Three's Company, adding more people and value to virtual visits. So Kyle, the microphone and platform are yours. Welcome.
Great, thank you, Bruce. Next slide, you already did my first slide for me. So a little bit about where we sit. I sit in Denver with the University of Colorado Family Medicine Clinics. We're 5 clinics spread across the Metro Denver area. We're part of the School of Medicine clinics, but we're affiliated with a larger umbrella UC Health integrated network, which is a nonprofit network of hospitals, provider groups, facilities across Colorado and a couple of our neighboring states. All of our 5 family medicine clinics are PCMH level 3 recognized. We've been in CPC Plus for years now. We have a large integrated care team process and culture. As you can see, we have lots of faculty, APPs, residents, learners from a variety of different fields. We went through a practice transformation several years ago where we improved our team functioning to have our medical assistants assist us more. So we have a large contingent of medical assistant support. The platforms that I'm using, just for context, we have Epic as our EHR with video, spelled with a Y, integrated in with Epic. And then we use Doximity video and phone as backup. Next slide. Here's what we did, which probably resembles what a lot of you had to do, which is turn on a dime in March. Back when I started focusing on telemedicine, which is in October of 2019, when we had a department retreat and said we need to focus on this as a strategic priority, obviously before COVID, we were doing a minuscule amount of telemedicine. By the April, we were doing 73% of all visits across all of our primary care clinics were virtual. That's over 75 times the volume that we did at our best month in January pre-COVID. We did that in April alone. You can see that our volumes dropped significantly, and virtual care really allowed us to maintain patient access and primary care volume throughout the pandemic. And now we're seeing that volume return, mostly through in-person, since Colorado has had a stabilization of our COVID rates, but still a significant amount, at least 30% are still virtual. Next slide. If I can impress on you one thing, this did not happen overnight. This was over 18 months, if not over 2 years of planning, preparation, local technical training, and dedicated on-the-ground support through virtual visit champions, staff champions, faculty champions at every single clinic, predating COVID. As you can see, there are a lot of different milestones here, some of them at the local level through training, and through piloting remote virtual visit sessions. And some of it was at the system level. And as you can imagine, with an organization with over 3,000 physicians and APPs, there's a lot of system and bureaucracy to work through. But a lot of that was prepared prior to COVID hitting. Next slide. That preparation, as you'll see on that next slide, really led us to be in a relatively well-prepared seat when we entered March. In February, we already had half of all of our faculty providers, medical providers, and many of our behavioral health clinicians, which are psychologists integrated within our primary care teams, had already had experience doing virtual visits. So by the time March came around, we had already had the training, at least something under our belts, that people, this wasn't a new thing for them. Next slide. During this transition, we found that it was necessary to bring in more people into the exam room, into the virtual exam room. And there were four basically buckets of areas where we had extra people adding extra value to virtual visits. The main one was having 3 or more participants in the exam room, the virtual room, for the whole visit. In-room scribing, which is a part of our primary care redesign with those extra medical assistant support, continued with virtual visits. Interpreter services, especially American Sign Language, Spanish, and others, having those people available via video really enhanced the experience. Patients with disabilities who had caregivers who needed to help, obviously parents of children that we see in our family medicine setting. The warm handoff, supervising trainees, both medical trainees, as well as psychology and clinical pharmacy interns, was important to have the ability for our supervisors to help train and educate our learners. And then these large group visits, which we've been planning around for advanced care planning, centering pregnancy and group counseling using health and behavior codes from our psychologists. Next slide. I'm going to highlight 2 of these in particular, the interpreter services and on-demand behavioral health, to walk you through what that workflow really looks and feels like in the ideal state, as well as some backup scenarios. Next slide. First, there are some common elements, basic elements that run through all of these types of scenarios of bringing even 2 people together, but really 3 or more people. Number 1 was having a telehealth platform that allows for more users to join. We had to change our license with video to have more rooms available, more licenses concurrently available for 5 or more users. That was a big difference when we only had 3 or 4 people using it at a time to hundreds of physicians using it at a time, that we had to change our contracts rapidly. We have preferred methods to make it easy and consistent for our patients and our care teams. And that's where the EHR and that portal integration, so using Epic's secure patient portal, My Health Connection, to facilitate the easy handoff and logging in and sharing the links. We also need a backup. We found that about 20% of people, for one reason or another, either technical glitches or aptitude for technology, this preferred method was too high of a bar for them to reach. So we have a backup, a standalone platform using Doximity Video, which was a great beta that went live in April and expanded access to an easy on-the-fly option for creating a virtual room. Then we also have these special and usually rare cases with HIPAA compliant versions of Microsoft Teams and Zoom that allow for, like this session, as many people as you want to scale to. The last piece is practice, prepare, practice, tweak, and repeat. There's never been one thing that we tried to do new the first time that worked. We've always had to tweak it and adapt, and we're still doing that with these sessions. Next slide. I put this up just to let people know that there is no one single platform that I've found or one single method that I've heard of that is perfect for approaching the technical aspects of bringing more than 2 people together at one time. You know, our Cadillac version of an EHR patient portal integration with video is great because it allows for single login for our care teams. We have synchronized e-check-in with consents, copays, collected insurance verification on the front end. The link is developed and shared from the moment the appointment is scheduled, so that gives time for a patient, say, to share it with their family member or their caregiver, so that they have the ability to come into the room at the time of the visit. But these extra steps add more chances for things to go wrong. Like I said, probably 20% of the time, this method doesn't work. And so having a standalone backup, whether it's Doximity or one of the other dozens of platforms that are out there, has been important to have that simple, very quick and easy way to develop something on the fly. Next slide. Going into a little bit more depth on the 2 scenarios of 3 or more people in the room. We chose interpreters because this is one of those key pieces where language is important to relay across the video experience, and having an interpreter there seems like the obvious right thing to do, but it's hard. So in our case at UC Health, we've contracted with a third-party interpretation company for years who have given interpreters access to the EHR. That has allowed us to schedule an interpreter at the same time as a provider appointment. And in good times, in pre-COVID times, that has allowed our interpreters, when we have on-site interpretation, to actually be in ambulatory clinics or throughout the hospital system at the same time in person with the patient. Well, we adapted that to allow them to also join the video room with similar mechanisms. Currently, the limitation is that we only have it set up for our 2 most commonly used interpreter services, which is American Sign Language and Spanish. We have plans to expand it, but that means that we need workarounds for the dozens of other languages that we help patients, or that we see that our patients speak. So we have ways to do that. One is to securely send a virtual room link to an interpreter on the fly. That's best, but it's hard. It takes extra steps. It also means that the interpreter, their way of actually logging their minutes, which is how they get paid and how their job performance is understood, they have to have a phone going live that's dead off to the side, not giving feedback at the same time that they're using video. It's awkward. Provider and patient on video and interpreter on the speakerphone. Just placing it on the desk, turning the volume up high and making the most of it. And then often this is where we have to fall back to telephone only calls, which is the easiest. Next. One of the other things that we have found incredibly helpful over the years is to have an embedded, integrated behavioral health program within all of our clinics. And then it's usually meant that we are able to walk down the hall, grab a behavioral health psychologist, bring them into the exam room with a patient who needs behavioral health services at the time of their visit. We all know the difficulties in handing off between a clinic and an outside mental health provider, where the median number of visits for a referral is 1. Well, we can accomplish that. We can exceed the median by just bringing in the person at the time of their primary care visit. So how do we do that virtually? Ideal state is that we actually have an on-demand behavioral health schedule, where we've actually been able to pool our behavioral health providers across our 5 clinics. When normally they were working in silos, they're now in a pool with one of them available for on-demand consultation. In the visit, when I see somebody struggling with substance use, even more in COVID, or mental health and anxiety, which is creeping up more and more every visit that I see people, I send them a secure chat message within our Epic EHR. They reply and say, "I'll be on in a second." They click the video, I introduce them to the patient, and either I stay in so that I learn something about the patient and mental health interaction, or I can do a warm handoff, and leave to see my next patient. Oftentimes, a behavioral health provider, you can imagine servicing 75 providers, they might be tied up at the moment, and they reply in the chat with a time that they're going to call the patient. If no behavioral health provider is scheduled at the time, either night or weekend, I still have to put in that referral, which then the queue is worked through a normal referral mechanism. Next slide. So as you can see, those two scenarios, you can see how some of those comments, the basic elements, plus some local adaptations and workarounds can work for all these different scenarios here, plus probably many more that I'm not thinking of that's more pertinent to your specialty and your local circumstance. Next slide. I was asked with this too as a life hack. What my life hack is for telemedicine is cannot stress the importance of over preparing your team with the ideal state, the workaround, the third backup, and option D through Z to meet a patient's need when they need it. Because if they're not prepared, if they don't know that there's a backup, they're never going to use it, and our patients can never benefit. So I appreciate the time, and I hope to answer questions as we go.
Kyle, thanks for that super terrific case presentation. Really amazing what you guys are doing there. First question is, could you talk just a little more about how you changed the workflow process and your use of technology in making the leap from 99% in-person visits last October to mostly virtual now? What was most helpful with those workflow changes?
Honestly, it was the ability for our patients to schedule virtual visits on demand. So we made changes to our phone room, which is a centralized call center that prior to the pandemic was not scheduling virtual visits. We made basically a whole host of virtual visit options and visit types available to schedule in every clinic. And we also made it an option to schedule through the My Health Connection patient portal that a patient can go on, search for Kyle, say, when do I want to see him, and actually schedule their own patients. So we reduced the barriers for scheduling appointments, was probably the number one thing.
Great, thank you. And as you were testing out the technology to optimize it, how did you go, what process did you use to test third-party applications to decide which would be the best for your situation? Did you have any pilots? What was that process?
I think that was more of an informal squeaky wheel process of, we had our centralized IT team that was supporting kind of the use case, that Cadillac version of EHR and video integration that met 80% of our needs. And that was excellent. And they were doing a transformation in and of itself. And to have people like me say, well, that it's only working 80% of the time, that's not good enough, you know, to offer them options of what else can we do. Doximity was landed on because we could get our staff and our providers on it, and it was free. And so it was free, it was HIPAA compliant, all the boxes started to get checked as we started to just pilot with 7 or 8 people that were kind of tech savvy and were asking questions. And eventually it rose to the top.
So you landed on using video and Doximity in different situations. Wondering if there are other apps that you think might be optimal for other types of situations, maybe not yours, but ones that would be relevant for others joining us today, other types of facilities or clinical settings.
You know, Zoom has been a great option. We found that, especially with the patients in rural communities, the bandwidth hasn't been as much of an issue as some of the independent apps that might be a little bit more clunky. Microsoft Teams has worked very well. FaceTime, the changes that the federal regulations have relaxed on HIPAA standards has actually opened up a whole host of other options that really lowers the barrier, the technology barrier, whether it's FaceTime, Google has a few options there too.
Great, Kyle, thank you very much. Now I'm gonna pass it to Dr. Christian Ramers, my co-moderator, to lead the Q&A session. Christian.
Great. Thank you so much, Bruce. I'm Christian Ramers, infectious disease doctor out in California. And it's my pleasure to introduce really a distinguished panel that we have for the remainder of the hour. We're going to do some rapid fire questions in several different areas. Some of these faces should look familiar to you if you've joined us at a prior session, but we do have 3 new panelists in addition to Kyle that I'm going to introduce very quickly. And there will be more extended bios available on Train. I'm just going to scratch the surface here. So first I want to introduce Elizabeth Krupinski. Dr. Krupinski is professor and vice chair for research at the Department of Radiology and Imaging Sciences at Emory University School of Medicine and a subject matter expert for the Emory Connected Health Program. And Dr. Krupinski actually started, it sounds like, at the Southwest Telehealth Resource Center and was co-director there back since 1994. She's the past president of the American Telemedicine Association, past chair for the Society of Imaging Informatics in Medicine, and vice president for the Society of Education and the Advancement of Research in Connected Health. So welcome, Elizabeth. Secondly, we have David Dansereau, and I should mention we have a very diverse group of participants from all different specialties here. So David is a physical therapist. He's a member expert in the Digital Medicine Society out of Cumberland, Rhode Island. He brings 20 years of experience as a physical therapist in a variety of settings and is now consulting with mobile health and rehabilitation technology companies. So welcome, David. And then our third new panelist is Tabassum Salam, who is Vice President of Medical Education at the American College of Physicians based out of Philadelphia. Dr. Salam is a general internist and medical educator and has been involved in creating Telemedicine, a practical guide for incorporation into your practice that's produced by the ACP. Prior to joining ACP, Dr. Salam was the medical director of population health at Christiana Care Health System in Delaware. And then our familiar faces to you, we have the group from Mary Center, Washington, D.C., Tolly Elliott, who is the Chief Medical Officer and is trained as an OBGYN with experience at Georgetown University. Dara Koppelman, the Chief Nursing Officer at Mary Center, also joining us again. Leah Cheval, who's the Director of Care Coordination at Mary Center, Washington, D.C. We have Faye McDonald joining us again, a Senior Workflow Engineer from OCHIN and the California Telehealth Resource Center. John Scott, Professor of Medicine and Director of Digital Health at University of Washington Medicine in Seattle, Washington. And Eric Shaw, Director of Gastrointestinal Motility, Esophageal Swallowing Disorder Center at Dartmouth-Hitchcock in Lebanon, New Hampshire. All right, so let's get to it. I'm gonna start, and just to frame how we're gonna do this, we have about 4 general buckets. We're gonna start with just sort of setting up telemedicine workflows, and I'll rely on Faye and Kyle and Tabassum for that introduction. We'll then get to how to get the most out of a telemedicine visit from Kyle, Dara, and Leah. We'll talk about telemedicine in non-primary care settings, and I'll ask the Mary's Center group, Tolly, David, Elizabeth, and Eric about what it's like to be a specialist or what it's like to use imaging through telemedicine. And then we'll finish with connected healthcare, and I'll call in Tolly and Elizabeth and John, Kyle, and Tabassum as well. So let's get it kicked off. And I should also mention, please feel free to enter questions in the Q&A. We also have a couple of ghost panelists I should have mentioned, Rebecca Picasso and Andrew Solomon from the Telehealth Resource Centers that are helping answer all of your questions. So let's get started. I think I'll start with Tabassum actually in terms of getting set up and getting started. One of the first questions that comes up is how does the time for a telemedicine visit compare to the time for a regular office visit?
Well, in my opinion, the actual time face-to-face with the patient can be comparable. If you're lucky enough to have as much as, say, 20 minutes or more with your patient, I think you should plan on devoting the full extent of that time face-to-face, whether it's in person or through the screen. That being said, you're going to rely on your whole team, and that team includes your patient, to have done a lot of prep work before so that you can dive right in. And not waste any precious minutes on getting logged on or technical barriers. And as Kyle, our first presenter today, very, very beautifully laid it out, have your backup plans in order. In case you have to abandon and go to telephone only, you want to do that quickly and again, not waste precious minutes.
Great, thank you. I want to go to Kyle actually. And so you've been working with family medicine practices and other practices. Is there a learning process in terms of getting things streamlined?
Certainly, there definitely is. I think the learning process has mostly been on the patient side. At first, we were taking 60 to 90 minutes on technical assistance just for our patients before they could log in to the portal. That's really started to reduce now that patients are coming back for their second and third visits. So planning on our medical assistants and staff to do some of that technical support prior to the visit, like Dr. Salamat had mentioned, is really important, so they're ready to go once the visits.
Thanks. And Faye, over to you. Do you see a practice getting more efficient as they start to introduce telemedicine?
I do. I think there is a large learning curve up front, and the more you can do to train and communicate processes ahead of time, the more efficient you'll be in the long run. Just have patience. I think one of the things that folks can really do is not make assumptions about their staff and their patients and their level of knowledge of technology. So making sure that providers and staff have what they need to be able to navigate whatever, if it's Zoom, Microsoft Teams, whatever they're using, making sure that they understand how to use that. And then also providing information to your patients to make sure that they know how to use the technology as well. And that would make your workflow work a whole lot easier when everyone knows what to do.
Great. Tabassum, back over to you. What would you say are some common mistakes or some missteps that people should avoid when they're getting started and getting things set up?
I think an over-exuberance and expecting that everything will fall in place quickly. To temper your enthusiasm, by all means dive in. I think a second important factor to making things, the sort of the genesis of a new program go well is make sure that everyone in the team, and again, I emphasize this, we're very focused on patient-centered care at the ECP. Patients are a big part of this, of your team. Make sure that you get input from everyone as you launch your program. Not everyone's going to have the luxury that Kyle and his team had of 18 months of ramp up. But take a little bit of time. Don't dive in too blindly. Ask everyone to chime in. If you're a physician or an APP or a receptionist, each and every single one of you is going to have input and insight into what it's going to take to transition probably to a hybrid model as most practices are reopening. How are you going to temper and balance your telemedicine visits and your in-person visits? Get the insights from people at the front lines, including patients' insights on how to launch and sustain and scale your program.
Thanks for that. I'm glad you brought up hybrid model. We've talked about this before. And Kyle, I'm curious, in the UC or University of Colorado system, did you see people going more towards hybrid model of mixing telemedicine with in-person visits or blocking specific times?
At first, when COVID actually landed in our clinics, when we had staff and providers actually get sick with COVID in early March, we transitioned quickly to be fully virtual for probably 90% of our visits. Now we've gone back and actually allowed the patients to choose. So our templates are open to either virtual or in person, and really allow the patient's choice to drive when they're seen. We do still have some virtual only clinics with providers remote, which has actually allowed us to expand access and capacity because we were kind of landlocked in our building. We can now actually have more providers using the same amount of space. So we have virtual only, remote providers, which are getting filled up about at 80% clip. And then we have mixed in-person virtual visits that are getting filled up at 100% capacity because again, it allows for a little bit of a mixing. Sometimes it's 30% virtual, sometimes it's only 1. So it does vary.
Great, thanks. And Faye, last one to you, and then I want to bring in the group from Washington, D.C. as well. What were some of the unexpected challenges that you had in implementation, and then how did you overcome them? Faye, in terms of the practices that you've been working for?
Lately, it's really the ramp up cycle has been the biggest challenge, especially with COVID beginning in March. Folks really had to get on get set up with telehealth and telemedicine very quickly. And so with that, we need to make sure that we have strong communication plans and strong training plans and develop things that staff can access very quickly. They know where to find things and be able to make sure that we are continually communicating updates and changes to the workflows.
Great, thanks. And over to the Mary Center group, what were some unexpected challenges? Maybe we'll start with Tali and then over to Leah and Dara.
I think the unexpected challenges were, much of which has already been stated. The patients certainly had challenges with understanding how to use the technology, understanding how to plug in. You know, with our population, we have 60,000 patients. We have a large number of individuals that have no insurance, 20% have no insurance. Certainly they may have devices, but then you have to deal with the data. Do they have access to the data to actually conduct the encounter? So many of those challenges were converted from video into voice. So it was a constant problem, but I think the biggest thing is just to overcome that is just to listen to the stakeholders and really talk to them and find out where you can meet them where they are.
Great, thanks. Nice to have redundancy and backup systems. Leah and Dara, anything to add?
I think that we've definitely, again, can echo everything that everybody else is saying. I think continuing problems and challenges that we're experiencing are meeting patients where we can't necessarily have the interpreters through the interpreter system that we have been using, and making sure that we are creating new systems to find interpreters that can work within the system that we are currently using as well.
Yeah, and I would just add, echo everything that everyone's already said, and just add, one of the challenges we also had in the beginning was for patients who didn't speak English, actually kind of instructing them how to use the platforms. The ones that we were using sent out instructions, but they were only in English. And so we would have to have our medical assistants call them and explain how to use it in Spanish or whatever other language. And then I think other people have mentioned just about broadband or lack of internet, or so we've been really fortunate that we've been able to do phone calls in addition to video calls and get reimbursed during the state of emergency. We're really hoping that that stays around afterwards as well.
Great, thanks. And just to remind everybody, we have a billing session coming up to sort of clarify, hopefully, some of those issues at a future telemedicine hack. A couple more questions just to wrap up this section. One of those came in through the Q&A, and I want to throw it over to Kyle from Rochelle Maracino. And that is, how do you handle a sensitive exam during a video visit? And since you talked about incorporating a third party, do you incorporate a chaperone or an attendant in those situations?
Yes, we can. That hasn't come up often. The time as it has is a rash in a sensitive or private location, and then it's up to the. Usually, we have our medical assistant with us, so they are that chaperone, and then the rest is really explaining and being upfront about what's happening with the video. I think there is some privacy concerns and stories going around and anecdotes that make patients wary of sharing their video over the internet. And so making them comfortable, and if they're not, scheduling an in-person visit to do it more safely and securely.
Great, thank you. And one last question. I'm going to throw this to Tabassum and then maybe John to bring in your opinion. It seems like it needs to be an iterative process. And I think Kyle mentioned basically a PDSA cycle, just tweak and redo, and a lot of changes for providers that are not used to changing what they do. So how do you effectively communicate the workflow changes out to your staff and then also to patients? Tabassum.
I think, again, if you lay the groundwork at the very beginning, we're inviting everyone on the team to be part of the change process is a great starting point. And then utilize there's always going to be a handful of people who rise to be champions of the change. Make it a group effort, and enlist all of them to take the messaging out. Recognize change fatigue. People will start to get frustrated and burn out from if you keep changing something every day or several times a day. To try and cluster those changes and allow at least preferably a day to communicate a change, let it sink in, take questions and concerns, try and address them, and then launch the change the next day. But just really continue to keep your eye on the the reactions of your team to temper their burnout and change fatigue.
Great, thanks. And John, for a big system like UW, how do you manage the change in workflow?
Yeah, I would second Dr. Salam's comment about having champions. That's key. A couple of things we've done is we have a regular newsletter that goes out with kind of tips and things like that. And then the other thing that's been really helpful for me is just to kind of walk around the clinics and kind of just see how people are doing and checking in with them, doing that more that personal one-on-one.
Great, thanks, John. Bruce, any other questions before we move on to the next section that have come through the Q&A?
I think we're good for the moment.
Okay, great. All right, so we'll move on to part 2 of our discussion, and that's getting the most out of a telemedicine visit. And I want to also tap on Kyle for this, since he's worked in practice transformation, and then Dara and Leah and others can chime in as well. So Kyle, I know you chose your one telemedicine hack, but what is your biggest tip for getting the most out of a visit as a provider? How do you train providers to get the most out of a visit?
Agenda setting, patient-centered communications is still apply over telemedicine. And in particular, which is interesting, we're finding the telephone encounter to not have those visual cues that normally progress through a visit, where there's a wrap up, there's an intro, the meat, and then a wrap up that you can see happen. The telephone seems like it just kind of lingers. And sometimes those patient-centered interruptions of, sorry, I got to cut you off there, let's wrap up here, are important, but having that agenda up front so you kind of lay some postmarks so that the patient knows how far you're going to get in that one visit.
Great, and over to Mary Center, in terms of agenda setting and setting the stage, is there a script that you gave your providers in terms of how to introduce a telemedicine or a telephone visit? We'll start with Dara.
We didn't give a script. We do have like consent type language that that we have put into our EMR, and so the medical assistant or the provider can review that with the patient. I think, with us, we were a little bit spoiled in that we had done a lot of telemedicine before this happened through our facilitated telemedicine visits. So a lot of our providers were comfortable from that end already and had to just kind of make the transition into not having a medical assistant facilitating the visit in the home and just linking up with the patient individually.
Tali?
Yeah, I think that any kind of change that, as had been mentioned before, there's always an element of reluctance. We're in the middle of a pandemic and people are freaking out themselves and worried about their family, and then they have to say, wait a second, I have to go do something completely new with this patient. For me, my recommendation to the staff was just to go back to first year of med school. Look at the chief complaint, look at HPI, look at the review systems, and then formulate an opinion, have an assessment and a plan. Understand that the physical exam is absolutely germane to the encounter, but sometimes that physical exam is not going to be had. And in this setting, that's exactly what it is. And so when you go back to something that people are familiar with, then they realize, oh, okay, I get it now. And that's actually how it occurred with us when we did the facilitated telemedicine visit early on. So like Dara said, we were spoiled in that we were already doing it. But when you took en masse, all of it, everybody, you really had to go back and say, just hit the pause button and go back to the very foundation of what you're doing when you see this patient.
Mm-hmm. Leah, anything to add?
I would say we also, continually work with all of our providers on empathy and making sure that they're really introducing themselves and going back to those basics of what Dr. Elliott was saying, and that trying to understand what the patient is asking and meet them as a person, not just as a provider. In addition, I think, it's also really important for every provider, every clinician to understand that, especially when you have video available, you have to use the cues around in the environment when you're looking at somebody. Looking at you, for example, Christian, is very different than looking at somebody like me on a video call, where you can't really see anything in my background, but I can already assess a lot from your background about where you are and what kind of statuses you're situated in.
Great, thanks. So the next question I want to actually bring in David. We're going to get to sort of non-primary care visits in just a little bit, but the question is, what are some tips and tricks and practices that you've incorporated to make the visit enjoyable for the patients? We have clients, we're doing some customer service here as well. So David, in the physical therapy visits, what have you done to sort of make patients feel comfortable with what they're doing?
Yeah, absolutely. Good question. I'll go back to what Dr. Elliott mentioned about getting a really good history. But you start with every session letting the patient know that we're in unusual times. I have patients that are doing the best in their can in their home, and their biggest fear is falling and possibly becoming rehospitalized. So I start every session with this little clipboard here. And we start by, basically teaching the patient, let's start with breath, start with breathing. And, we've been doing this with some of my patients that, go down the order, don't forget to smile, share, tell people what's going on your right, share with family members, and then kind of rest, rinse and repeat, because, this could be a long process, but, go back to for physical therapists. This is new to a lot of us, and go back to the skill set that we learned. You take a great history, and the patient will tell you. They'll almost arrive at the answer of what they're looking for from that session.
Great, thanks. Tabassum, over to you. Any tips and tricks to make things a little bit more patient-centered and keep patients comfortable with the technology?
Absolutely. I think there's nothing wrong with the APP or physician or psychologist, the healthcare provider, to acknowledge to the patients that they too are new to this, and they're learning, they're adjusting. If you're genuinely warm and empathetic, it's going to transmit through the screen. If you have the privilege of continuing with an ongoing patient, hopefully you can pick up right where you left off the last time you saw each other in person. And even if it's a new patient that you are meeting for the first time, these are basic skills, and I think they translate from in-person to virtual visits. Be warm, be welcoming, and be human. Welcome them to recognize that you're a novice too, if that may be the case. And if you're not a novice and you feel a little bit more expert, reassure them that you started from from 0 and look how far you and other patients have come. Try to really dispel the myth that the virtual platform will erode the provider and patient relationship. It'll be as good as, perhaps even better, if the patient otherwise couldn't have access to you.
Great, thanks. And I saw a request for David's whiteboard to be displayed again. So there you go. The next question, we do have a whole session later on in the series devoted to physical exam. But John, I wanted to ask you just very briefly, any best practices for incorporating physical exam in telemedicine?
Yeah, first, as part of your preparation process, ask them to get like a thermometer, get a flashlight, because you might be looking at their mouth, the oral pharynx, things like that. And then if they have any kind of devices at home, like a scale or a blood pressure cuff that can get a heart rate, those are great to have ahead of time. And then just make sure they're in a private place that you can kind of do the exam virtually.
Great. I'm looking at the clock and seeing that the hour is fast dissolving. So I want to bring Elizabeth into the conversation, and David, especially in this next section, which is sort of getting into non-primary care visits. So Elizabeth, I'll start with you. What are some common misconceptions about telemedicine in non-primary care?
Well, the main misconception is that it can't be done. But outside of primary care, I mean, there's so much evidence in practically every clinical specialty that there are amazing things that can be done that are absolutely feasible. There's a ton of published literature in behavioral and mental health, in stroke and neurology, in gastro. Even in my area, radiology, we are increasingly using telemedicine to connect with patients prior to their visits. For example, patients coming in for a biopsy, to explain the procedures. I mean, you've got, a cancer diagnosis potentially, yet it's COVID and you're not supposed to come in, but you don't want to delay treatment. So having a visit with the patient to explain what's going to happen during the visit, follow up afterwards. What do you do now? You've got a guide wire now inserted. What are the next steps? Who are you going to next? Our interventional radiologists, who are still doing numerous procedures, are connecting prior to and after visits with their patients. So even the clinical specialties where you think, where would even telemedicine be used? You're just shipping images, who cares? our providers are actually connecting with patients virtually and enhancing those visits. There's really very little, I mean, obviously surgery, you can use the Da Vinci robot, and, there are alternatives for the actual surgeries, but I mean, there are certain things that absolutely cannot be done. Dental procedures, I don't want a virtual drill at this point in time. But for the most part, there are a variety of aspects that you can really do a lot of good triaging and assessments of patients before saying, okay, we've done as much as we can, let's move on to in-person.
Great, thanks. And David, over to you. Physical therapy really is one of those areas where physical exam is so important. So was there a special adaptation to the workflow or special education for the patients that was required before you could go live?
Yeah, that's a good question. I would suggest that physical therapists actually, if they're able to, film a quick onboarding video. And I have an example on the website where I'm treating that I can share, because it kind of sets the stage and takes someone through, takes the questions out of what they're going to expect from PT. You can do just about everything in remote PT except manual therapy. I haven't figured out how to get the hands through the screen yet, but it takes that learning process. And a lot of that is vetting your vendor, because a lot of the things that you can't do, if you have a vendor that can provide outcome surveys, you can get a better feel. And then it was mentioned on the last comment about if there's remote monitoring tools that are only going to get better and better, like watches and blood pressure, you can kind of get those, you can get that biofeedback. But the other important thing is when you're doing a treatment, the patient has the benefit of the biofeedback of the screen. And that's really important. You can use that and work off that so if there's an asymmetry or just the quality of their motion. And it's really teaching the patient to empower the patient to take charge of their own condition.
Great, thanks. And I want to bring in Eric Shaw, a GI doctor here, considered essentially a procedural specialist. How do you incorporate telehealth into your workflow as a proceduralist?
Yeah, so the first step for us was to really recognize what telemedicine is, which is it's a tool. It's a tool to help us address access challenges. And there's a really robust body of evidence that AHRQ put together that shows that telemedicine actually solves access problems between primary care and specialists for complex chronic diseases. So there's really a lot of body of literature in that area. But it's specific to the types of diseases that we treat in each of our specialty practices. So I showed what we do in motility. There's also inflammatory bowel disease, there's cirrhosis, and then outside of gastroenterology, we think about heart failure patients, very different from patients with autoimmune conditions. So the three things that we tried to focus in on are A, what's our practice model? Are you in a small or a solo practice, a large single specialty group, hospital employment arrangements? Do you have PSAs with your local hospitals that you might look at? Two, what are your location challenges? Are you in a big city that faces public transport challenges? Patients having to transfer on multiple buses to get to the appointment. For us, we're rural. We have beautiful mountains, but we have beautiful mountains between us and the patients. And some of our patients need to be getting infusions and getting frequent care that we provide as well. And then third, trying to be as specific as possible, that it's not a one-size-fits-all, and that if we deploy telemedicine within individual workflows to match specific patient needs, will probably be more effective. So dive into the local access issues, build the telemedicine program around it, and keep learning from others.
Great, thanks, Eric. So we just have a couple of minutes left, and I want to just finish with the questions about team-based care. For a physical therapist or a radiologist or a proceduralist, you're not going to be able to take care of the patient by yourselves. You need a whole team around you to help. So Elizabeth, over to you. What are some emerging best practices in terms of incorporating the rest of the medical team?
Yeah, it's really a matter of logistics and cooperation. It's hard in real life to get a team of providers together in the same room with the patient. Your radiologist, your oncologist, your cancer nutritionist, and so on. It's hard enough in real life, let alone virtually. So a lot really depends on your scheduling and your logistics. Sometimes the model that we found better is to actually do it, sequentially, where, you're going to meet with this person first and this person next. The problem there is figuring out which is the best order to have people seen in. Do you want to see the radiologist first to just kind of explain the results, and then the radiation oncologist to explain the next steps, and then the nutritionist, for example, to explain what's going to happen next? It's almost like a tumor board, and that's sometimes impossible to get people together as well. But it is critically important, and you don't want, the few key providers that are needed to fall through the cracks and then not see the patient. So what we found is really to have a central coordinator person who can really take charge of, like a patient navigator, really. You're in charge of this patient and making sure that all of this happens. Unfortunately, it has to happen virtually.
I see Leah nodding to the patient navigator comment. Only a couple of minutes left, but I want to bring in David and Tabassum. Let's say that you're a physical therapist and an internist, and you have to work together. What, from your perspective, Tabassum, as an internist, what would you need to do, and then how would you appreciate the input from physical therapy or ancillary specialty?
I think the great advantage that the virtual platform brings is the ability, as we let off the hour with, of bringing in multiple people at the same time to co-partner and co-treat a patient. It's wonderful to just have a 3-person conversation: patient, my PT colleague or OT colleague, and myself. You could swap out any other disciplines. I've had great experiences working with a social worker, my patient, and myself. We can all talk at the same time, hear the same thing. I think it speeds up the communication and avoids any miscommunication that used to happen in the past through letter or electronic typed communication, or the very old days, handwritten communication. So I'm curious to hear my other colleagues, how do you receive it?
David, let's go to you. How do you?
Yeah, I agree, and I think, and I'll use a perfect case example of a patient with Parkinson's, for example, who may see their neurologist twice a year. I can write a long progress note, but I can get on, and I've done this, with the neurologist at the time of their visit and look at how they've trended, what they've been doing, how their mobility scores have been going up or down. So it really gives that FaceTime, but really that ability for the patient to really feel like this is coordinated care. I don't have to explain myself to what, in PT terms, what I want to relate to the neurologist. It's right there. We're live and we're talking.
Thanks. And those of us involved in Project ECHO and the ECHO model, it's amazing to see when you get diverse specialists around the room talking about a single patient. It's actually the most efficient way to really deliver multidisciplinary specialty care. So I'm sad to say that we've reached the end of the hour. Thank you so much to all the panelists for your expertise. I'm sorry I only gave you a couple of minutes each, but thanks for everybody's attention. Please keep the conversation going on our train discussion boards, and I'm going to turn it back over to David to close the session.
Thank you, Christian. Thank you, panelists. And keep in mind to the audience that the Q&A transcripts, we are collecting those, and we'll get some of those questions that weren't answered during the session answered later, and then we'll post them to train the following week. So stay tuned for that. So we can pull up the next slide. I have some quick announcements. First of all, just always want to remind folks there's a train user guide to help you get to the discussion boards. Next slide. And then with the discussion boards, we have these 8 topical boards where that peer-to-peer engagement, you can actually pose new questions, get them answered by peers and experts. But if you just want to have a library, I wanted to highlight the slides, recordings, and session materials for discussion board, because that's where all the materials will be kept for the full 10 weeks. So we can have it all in one place. Next slide. Some other updates, trying to listen again to the feedback that we're getting from the community through different kinds of qualitative data or comments that we receive. One new feature I wanted to share is what we're calling TRC picks, Telehealth Resource Center picks. These are some of the most frequently used telehealth resources by the TRC staff. And an initial list is at the last slide of this slide deck that is shared already, and we'll also have that on the discussion boards. I also wanted to give a heads up that we're going to be doing a midpoint survey after next week's session. So for those of you that joined Initially with Telemedicine Hack, we had a baseline survey with 1,005 respondents. We'll be doing a midpoint survey, and our community has certainly grown since the first week. And then we'll also do a survey at the end at 10 weeks to kind of track progress and see how we're doing with telemedicine implementation. One major change that we're going to make to this midpoint survey is that the baseline survey, only healthcare providers were really able to answer the questions. And now that we realize that approximately 40% of our audience is non-healthcare providers, we're going to modify that survey so that everyone has a chance to provide input. And then last week I mentioned the save the date for a bonus hack. We actually have a date for this extra session, kind of a deep dive on a specific topic outside of telemedicine implementation proper. And this session is still being developed, but we've got a date of Thursday, September 3rd at noon to 1 Eastern time. And we'll send a separate invite and registration for that. I just want to give folks a heads up. Next slide. So the next two sessions are actually on billing and reimbursement. And this was based on the registration question that folks answered, the #1 pressing need of the TM hack community, with about 20% saying this was their #1 issue. And so we know this is going to be very important for many of you. And just as far as level setting for the next couple weeks, we wanted to just share that what we can cover and try to make this as germane and relevant to our diverse community, this will really be on kind of on an overview level. We'll talk about different factors that impact reimbursement and talk about maybe how those factors can be used in different settings, but not get too in the weeds on particular individual situations like how do I fill out line 62 on this state Medicaid form. This is really going to be higher level. We hope it's going to be very helpful for folks. And of course, we'll always have the office hours afterwards, which is week 6, to really try to get as many of these questions answered. Next slide. So then with our roadmap, I just wanted to share, we're going to move on next week to session number 3 on the telehealth billing and reimbursement policies. And I just want to add the case presenters that we have confirmed for next week. We're going to go coast to coast. So we'll start out with a dermatologist from San Francisco. And then we also have a substance use disorder treatment provider from Maine. And next slide. And with that, I just want to say thank you again for another great session. Thank you to all of our partners, and I'll hand it over to Bruce.
Great, thank you, David. Just want to wrap up with a huge thanks to Kyle for sharing his experience from Colorado. It was a wonderful case study, and to all our expert panelists and to Christian for the great moderating, and in particular to the more than 1,500 participants today. So a reminder, take advantage of the CME and CPD credits. We really value your feedback, and everyone take care, and we look forward to seeing you in a week.